let's start the session. You know, I've attended. I've attended India Policy Forum meetings for now, I don't know, since it started. And one compliment to the organizers is that I've never seen such strict adherence to time, broadly speaking, plus minus 5 minutes. We all remember the occasions when it went overboard, etc. So I also want to try and adhere to that. The topic, as you know, is on COVID. It may have been called disease surveillance, etc. in the paper, but it is COVID. And it is a pandemic. And the pandemic, not a pandemic that hit 3 countries, not a pandemic that hit 4 countries, but a pandemic that probably hit 140, 50 countries, and still counting in terms of its effects. So it is, it is a problem of our times. And what happened, why it happened, what should have happened, and what should the governments have done differently are some of the questions that Anup will try and answer. I only very recently got the paper, but glancing through it, I thought an alternative title of the paper could have been Everything You Wanted to Know About COVID and Were Afraid to Ask, or were willing to ask. So I think it is a very, very comprehensive paper. It covers a whole host of issues, and I did look at one sentence that says that, look, he hasn't considered vaccinations because the paper is already too long and has already covered very exhaustively. So please don't blame him for not including vaccination. I don't think it is that important to this paper. We all know that vaccination helps, and even there's a controversy as to how much it helps, and it will just raise questions more than answers. When I started to look at the paper, what I would like to have it, and I haven't read it quite intensively, so maybe the answers are there, is, the world has had pandemics before. Not universal, but localized. But I don't know of an instance where lockdowns were exercised. So one question that I'm looking for, and lockdowns came as soon as in Wuhan on January 21st or whatever. It may have happened, COVID may have entered the world before, but on January 21st. So the first approach to countering COVID, this is January of 2020, and last I heard in China, they're still having lockdowns 2.5 years later, that the first response was, let's have a lockdown. The next response from practically every country in the world, except for 4 or 5 exceptions, and I hope Anup will discuss those, was a lockdown everywhere. And India had, according to many and most data, and according to Anup as well, and I don't have much disagreement with that conclusion, that we had a very early lockdown and a very strict lockdown. Now, if one reads through I've never seen so many research working papers in such a short period of time as when COVID hit. And the institution where I'm at, the IMF, was at the forefront of publishing papers and explanations and recommendations. And one big recommendation contained in the WEO of October of 2020, so barely 9 months into COVID, was that what works are strict lockdowns and early lockdowns. According to that criteria, India should have been a star. Maybe it was a star because it did. India was also one of the countries that emerged very early from a strict and early lockdown. So why did it do it? Now, one sentence that Anup has is that the four issues or the four questions that it seems to answer, and the last one is, what should India have done differently? And the first three questions actually lead up to what should India have done differently. I should warn you, and I'm sure that Anup will mention, that practically every instance that Anup cites in his very, very comprehensive paper is that, look, this is what happened in India, and this is no different than what happened in the rest of the world and the rest of the countries. It's not just the rest of So I think this is a complicated issue, and we have the best person in the world to help explain what happened, why did it happen, and what should have happened. Thank you. And 30 minutes, as you know, the organizers have been very strict, and I think I should have those sheets over here. Yeah. Okay.
I'll be setting a stopwatch just to make sure.
Yeah.
Thank you very much for that introduction. I will answer your question, I think, afterwards, just so that I can cover the materials in the paper. So let me go ahead and begin. So let me give you a quick overview of what I'm going to try to do in this paper, or in this presentation. I'm going to try to give you a quick review of what surveillance there was, both epidemic surveillance, so disease surveillance, and economic surveillance, what there wasn't, and try to give you some explanation for why or why not those moves were made or not made, and then what we did and importantly did not learn from that surveillance. I'll also give a lot of policy recommendations, things that we could change, but I'll try to be a little bit modest about the chances of those actually occurring or political obstacles for those to those. There are going to be a few big themes that you're going to see. These are kind of economic themes, as well as, I would say, administrative themes that come through. The first is we really have to think about the incentives for gathering and disclosing information. There's a lot of incentive not to do that, and so what would seem like intuitive steps we didn't take. Second is, in order to do data gathering, you really have to think about the infrastructure for data gathering and have that ready ahead of time, and we didn't. And it's very hard to build that in a crisis, especially when there are bad incentives for data gathering. Third is, a lot of people think of data as a public good that the government should furnish. I think one of the things that I've learned during this pandemic is that private provision of that data is a great idea, both as a check on what the government's providing, but also because there can be private incentives to provide this. Remarkably, during a pandemic, a lot of people suspend their self-interest and try to act in the interest of society as a whole, and we saw a lot of that, quite admirable in India and elsewhere. I think we want to capitalize on that the next time a pandemic comes around. So we should think about private provision. And the last one is we just have to be better at merging different types of data, interpreting that data, and critically changing policy when we learn something about the pandemic, which we are very loath to do. Okay, so I've divided the paper into sections that go through the pandemic, basically through 2021. I don't deal with Omicron. I didn't get to vaccination, but I don't have time to talk about all of it. So I'm going to skip the section of the paper that talks about what happened when cases first arrived, before cases first arrived, and when cases first arrived in India. So this is the kind of the period from, say, January to early March. And I'm going to just jump ahead to talking about the surveillance that we began, let's say February, March 2020, pre-lockdown. Before then, I'll step through lockdown and the post-lockdown period. Okay? All right. So if you're, for some of this is going to be a bad memory. For me, it's a little bit of that. So one of the first things that we did when the pandemic hit is that we focused on testing symptomatic people and testing them in hospitals. Now, I think the reason why that happened, despite the fact that we know now that there was community spread of the infection, a lot of asymptomatic cases, I think the reason we had that, and we saw that in lots of places, so India was not unique in a lot of these moves, is because we had a medical doctor's treatment perspective, which is people come to you, you do the tests if you can do something about it, and we thought we could do that for people that were, experiencing symptoms. We saw that we could, kind of help them with ventilators or lying prone in hospitals. That became a little bit later, but we didn't think about people spreading it when they didn't have symptoms, and we didn't think about wanting to know what the population level statistics were, so we see how quickly this thing is spreading and how non-medical interventions like suppression, how important those could or could not be, okay? I think you could also make the argument that there was some degree of rationality here, which is, look, we have a limited supply of tests. Who should we spend them on? Let's spend them on the people where we could actually help them. Now, that was, I think, a charitable interpretation. I'm not sure that's entirely true. We did have a lot of capacity to expand, and we didn't expand as much as we could have. There's also a little bit of effort to reduce panic. We don't want to tell people that they're spreading the community, otherwise they might panic. I think that's a little bit problematic. It presumes that people are rational. I think one of the things that we learned in the pandemic is that there's a lot of rational voluntary social distancing that was going on. And so we want to be a little bit careful about that going forward. Now, one consequence of this focus on symptomatic hospital cases is that we underestimated the infection rate because we weren't counting the asymptomatic groups. We also underestimated the degree of community spread, which meant that basically our efforts to control were a little bit late, especially using non-medical interventions. So again, the lessons from there are very obvious. We should approach these problems with public health rather than a medical doctor's mindset. Institutionally, what does that mean? That means maybe NCDC should play a more prominent role than just Ministry of Health within, not just at the high levels of Ministry of Health, having NCDC involved. Maybe a slightly smaller roles for ICMR. I think might have been an interesting change we could have made. The other thing is that we shouldn't make assumptions about what a disease looks like before we surveil. Just assuming that you know what's going on, we've learned could lead you to very long results. If you're thinking about limited number of tests, the way you should think about this is, yes, it's limited, but the marginal value of a small amount of population-level testing is very, very high. Maybe it shouldn't be a vast majority, or a large percentage of all the testing early on, even though it's limited, but on the margin, it's got to be somewhat helpful. And so it was kind of, I would say, not rational to do the, to adopt a corner solution, which is functionally what we did at the beginning. The other thing is that you'll notice at the beginning of the pandemic, we focused on testing for current infection, so RT-PCR testing, and that makes a lot of sense. At the very beginning, we already had PCR machines available around the country. It's a tried and true method. It's very sensitive, and so you can pick it up. So that part, I think, makes a lot of sense. But I think after a while, it doesn't make as much sense, and there's two reasons for that. One is that RT-PCR tests are too sensitive, which means that once your body is cleared an infection, it will still have viral fragments that can be detected by a PCR test. And so in some sense, it's likely to find that you have the infection even when you don't, which is a little bit problematic. And then the second thing is it doesn't do a great job of revealing future risk because it doesn't tell you what the probability of infection is going forward, which is a function of both your kind of basic disease parameters, like the rate at which it spreads, the recovery rate, which is important, but it also depends on susceptibility, the number of susceptibles in the population. As that declines, your current reproduction rate declines. And infection rates don't really capture that. And especially if you measure infection rates poorly, meaning you only look at it for symptomatic, you can't even look at the stock of infection rates in positive cases to figure out what the number of people are that are left over in the susceptible category. So that was, I think, a little bit difficult or problem as once you got into 2-3 months into the pandemic. What's the solution? Well, we could have tested representative populations even with antigen testing, with RT-PCR testing. We didn't. That would have been able to help us measure immunity over time, and we should think about doing that next time. The other thing is that you could have solved this problem also by making the assumption, okay, look, the spread of disease among symptomatic cases is similar to the spread of disease among our asymptomatic cases, that the positive rate, the trend is similar, and then I'm going to use that along with a SIR model, categorical, a compartmental model, like an SIR model, and then kind of estimate what my current reproductive rate is. That's not the only way. There's some non-parametric ways to do this too. We've done that. So for a number of states, we provided those estimates on a week-by-week basis, and that's this paper that I've got over here, done with Satej Soman, Luis Betancourt, and a large team, actually. And I think Sam was also involved in that paper. So you could do that sort of thing, and we should think about having that done next time. Here's another third issue that came up early in the pandemic. You'll notice that what was being reported was the number of positive cases rather than, and you weren't getting information on the tests, and therefore, or at least early on, you weren't getting a great deal of data on the positivity rate. And again, I think the reason for this is that we were thinking like a doctor. Policy was being driven as if a doctor was making the decision. You're thinking about cases, not rates, because you're not interested in the population. You're interested in the number of people that you need to treat, let's say. And again, limited resources in terms of administrative capacity to report data. That might explain why it is that early on we didn't have great data on the number of tests being done, and thus the positivity rate. But even when we did, we kind of screwed things up a little bit. And here's the reason why. So, think about the positivity rate. That could tell you a lot, even if you just make the assumption that symptomatic and asymptomatic trends are the same. The difficulty becomes if you change your selection, if selection changes over time, that is to say the sample that you're testing or the measure of, or like the criteria that you use to test the population, because then you're a little bit worried about those trends changing over time. The problem was we did exactly that. So if you remember, again, this is requires you to go enter the Wayback Machine. One of the things that we started doing early on in the pandemic, and it wasn't, again, just not only in India but elsewhere, we would use the positivity rate as a tool to determine whether you're testing enough. And that was a real problem, because what that means is that your testing rate, your outcome variable, and your input variable depend on each other. It's very hard to interpret that, especially when we didn't actually know the relationship, what the criteria was for determining when you're going to increase the testing and who you're going to test. Okay, so what are some of the lessons? First is, report testing rates. Second one is to decouple testing rates from positivity rates, or at least make it regular and transparent so we can adjust for that selection. A third is, announce changes in sampling too. So even if you're naive about it, you know that within the short periods when sampling doesn't change, I can look at trends. Okay, here's a fourth one. It's not about surveillance per se, but it's very much related, which is the government controlled information in order to control the panic. I'd mentioned that a little bit earlier. So the example was community spread. One of the arguments, Love Agarwal, who we work with, one of the early announcement he made is that we don't want to be careful about panicking the population. There was an implicit assumption, I think, going on that just people are rational. Maybe there's too many people are watching too many Hollywood movies where people just panic aimlessly. And I think that the empirical evidence that we've seen since suggests that it's not entirely irrational, that a lot of rational behavior can explain people's response. I'm happy to go into some of the specific studies that do that. And so I think that that's a problematic assumption. The data, well, I guess I'll say a little bit. There are two pieces of data, I think, that illustrate that. The first one is, and no disease model without human behavior that's rational can explain this, which is that if you look at the reproductive rates for the disease, you'll find that they linger around 1 for extended periods of time. And that's very hard to explain with an SIR model. You can't use an SI model, which could generate that, because the SI model can't explain waves. So we really don't have any really credible way to explain this kind of behavior other than people adjusting their risk-taking depending on what the current level of risk is and maintaining at a particular stable rate. A second piece of data is actually, if you look at I think the better studies on lockdown, trying to figure out, does lockdown have a big impact? And I think the better studies that do a job of trying to control for voluntary social distancing actually find that no, it doesn't. And implicit in those studies is that the people do privately respond to risk independent of what the government does. Although government information can inform some of that risk. So making the assumption that people are rational is not a great one. There's another problem with this, which is the story that you're just trying to protect people from information so they don't panic can also be a cover for just hiding bad performance. And so and hiding criticism. And I think that that's a real danger in this context. And by the way, again, India is not unique in this. This is countries around. I'm in Illinois. Illinois it can be argued that we did the exact same thing. So how do we solve this? So I think some of the lessons that we learn or recommendations that come out of this are, the government should commit to regular surveillance and disclosure, even in peacetime, and especially in crisis. I think a good model of this is Tamil Nadu's Surveillance. I'm a little biased because I worked with them on it, but I think that having that regular commitment to doing the surveillance and disclosing it means that when they don't do it, it's really observable, and so the government looks particularly bad. So there's a lot of pressure kind of to keep their feet, kind of holds their feet to the fire. Another thing is that we should really think about making space for independent, whether it's international, WHO, UN type surveillance, or private surveillance. So I'm a big fan of the CPHS data set for doing independent surveillance on economics and on death. And I think that more of that is better, not necessarily just from CMIE, which is the manufacturer, but other companies as well. We'd like to see more of that. I think I'm on item number 5. Another thing that you probably saw early on is there's a lot of contract tracing, massive scaling up of contract tracing in India. And why do we do contract tracing? Well, it's just a standard response to the pandemic. We'll get to the lockdown in a little bit, but if you talk to an epidemiologist, especially somebody from CDC that's in the epidemic information services, the first thing you do at a pandemic is that you trace contracts to learn about the disease and then maybe to control it. So it's not surprising that this was done. The problem is contact tracing, when you have a high reproductive rate, basic reproductive rate disease, is very difficult. You just can't scale the number of workers and trace contacts fast enough to keep up with the disease. And we learned that very fast. And so I think it was fine to do the contract tracing. I think that we spent too much time doing that, even when we knew it wasn't really making that big of a difference. Also, if you talk to any statistician, the problem with contact tracing for learning about the disease broadly at the population level is that there's selection bias in this form of snowball sampling. So there's not that much we could learn about the population in this too. The last thing I think is really problematic is, that said, we still learned something super important. So this is from Lakshminarayan's science paper in 2020. We learned that there was massive dispersion in reproductive rate. So we are usually told, oh, reproductive rate is 3 or 5 or 10 or 17, depending on the variant that you're talking about, right? But what we don't realize is there's massive variation amongst the people in this room in your personal reproductive rate. And we learned that through contract tracing. So 5% of the people were responsible for 80% of the positive contacts. And this wasn't the only place. There's another group led by Professor Endo that has done this elsewhere in the world. It's a regular pattern that we see. We have not updated on the basis of that. We've known for a long time through modeling, from at least back to 2005, that when you have high dispersion in reproductive rates, lockdowns, broad-based policies don't make a lot of sense. What we should do is go investigate who are the people that have higher reproductive rates, and then try to target those people and try to get those people to be restricted because you minimize the cost of the infection. I understand there's equity issues there, but at least it's something that we should have been doing to see if there truly are equity issues there, but we didn't do very much of that. We really just kind of let this huge finding in science sit around. And it's not the only one. There were a few others as well. Okay, so what are the lessons? Well, contact tracing. By the way, what's really interesting about contact tracing is that what you did is you started with a symptomatic positive case. Then you looked at contacts, and then you tested the symptomatic positive contacts. So you were making the same mistake as you were doing with the hospitals, right, at the beginning? So one thing that you could do to solve that is to say, look, if we're going to do contact tracing and we want to make it useful for sampling, despite the bias from snowball sampling, let's at least do some random testing of the contacts to determine what the population level spread is. Yes, selection bias, but it's better than nothing. So we should at least try to do that if we stick to contact tracing going forward. And I would do that even with the low R disease. Again, we don't know until it actually happens, but it would be good for us to figure out, in fact, that low R is truly that case, depending on what's happening with the random sampling. Also, act on the fact that there's high dispersion. By the way, to this day, we don't act on this fact. I think it's one of the probably number 1 or number 2 in terms of shocking failure to respond in updates that we've seen. You can say it over and over again, and people aren't changing their behavior. They're not denying the underlying fact either, which is really problematic. Okay, here's another one. You'll remember that a lot of people had to quarantine. If you were symptomatic, typically, you were positive, you had to quarantine. Lots of debates about how you're going to quarantine. Now, look, quarantine makes sense, right? It limits the spread, at least of the person that you find that's positive. Again, maybe you could tell a story for why you focus on the symptomatic folks. There's limited supply of tests. You want to ration them well. The problem is that you have asymptomatic spread. And if there's asymptomatic spread and you're only quarantining the people that are symptomatic, you're not really stopping the spread. So the return on the quarantine is very little, especially when you have an exponentially growing disease. Okay? So you undermine the quarantine efficacy with only symptomatic quarantine. It's also the case that we didn't think about the incentives. And I learned this through personal anecdote. We've done a lot of serological testing. And that serological testing in different states, sometimes we just do antibody tests, sometimes we do RT-PCR tests, sometimes we do cellular immunity tests. The only one of those tests that inspire opposition is RT-PCR tests. And the reason is they don't want to be quarantined, which tells you right away that if you're going to quarantine and you announce that you're going to quarantine these individuals, you're not going to get people that are positive, even with symptoms, to come forward and get tested. They'll hide those symptoms. And you don't have the capacity, even the US doesn't have the capacity to make sure that everybody's getting tested across the board. And so you really have to think about, what is the benefit of quarantine? Okay, maybe you limit the spread, but the cost of quarantine is you find out less about the infection, and you're not quarantining all the relevant people. Okay, so again, what are some of the lessons? Look, you need to think about what incentives are for getting tested. Early in the pandemic, you're probably not going to have a great treatment, so that's probably not going to encourage testing. You need to think about that up front, that it's going to be very difficult to get all the information that you want from a disease. It's really good to have established, say, a sample that you're going to test repeatedly, a random representative sample, before the pandemic, so you can keep track of these individuals. Otherwise, you can't expect them to come to you. Another thing that you could do is you could say, I'm going to give people incentives to actually go get tested by giving them immunity passports. Most people think about immunity passports as problematic because if I gave you immunity passports, you would go out and get the infection so you could get the passport, get exempted from lockdown. Separate question about whether we should do a lockdown or not. But the flip side, the positive benefit of immunity passports, it encourages people to get tested. So that's something that we should really think about next time around. So now let's talk about the lockdown. Okay, before we talk about lockdown, I want to talk about the uses and abuses of, I'll keep track of time here, the uses and abuses of disease modeling. Look, early on in the pandemic, there were a bunch of disease models put out. They had wildly different predictions about the number of deaths and arguably influenced policy and maybe even the lockdown. Why did that happen? Well, I think knowing modelers and even public health folks, it was a once-in-a-lifetime opportunity to talk about your own academic work, and typically these are academics that were doing a lot of this work, and I think that they might have pushed their models a little bit too far, and I think that I understand the temptation, but probably wasn't the wisest thing. And they should know that there's going to be massive amounts of error because what you're doing is you're looking at an exponential process and you have very little data to discipline the parameters that drive that exponential process. So the errors are going to be massive, or potential errors are going to be massive, and they didn't caveat it that way. We didn't know a lot about the disease. I mean, actually, this is really surprising. It was a coronavirus. Coronaviruses mutate. That's why we have very little protection against them. And yet at the beginning, nobody was talking about viral evolution. Right? Everybody's using SIR models and models, kind of simulated models based off of SIR models in a situation where we know coronaviruses evolve. So those are particularly bad. We're also using models that, I already talked about this. SIR and SI models are not particularly good with viral evolution. And importantly, these models didn't account for human behavior. I mean, I think this is the biggest glaring omission. At least in the US, you'll hear this from epidemiologists all the time. Why did your models fail? Well, we didn't think about human behavior. I think that's kind of well established at this point. Whether we do something about it is in our control, and we haven't yet done anything about it. But I think that's another source of error in the models and their forecasts. So what are the lessons? Well, the first lesson actually comes from an experience that I had that I haven't listed yet, which is that early on in the pandemic, while there were some modelers approaching the Indian government with forecasts, from what I can tell, basically there was one of them that was domestic and the rest were foreign. Okay, and then we went around trying to find modelers in India, and it wasn't very easy to do so. A lot of the modelers we found were abroad, and it's actually kind of hard to get them to reorient their attention to India. And so you'll notice that a lot of the modelers, myself included, are non-epidemiologists that learned the models. I happen to have known them before because I'd done some infectious disease work, but a lot of them learned them afresh and then started doing them, and that was great. But what it also tells you is maybe we should invest in domestic epidemiology and particularly mathematical biology expertise. I think that would be particularly helpful. We should also kind of do a little better job of connecting the surveillance that I was talking about before to the models. So the models are a little bit more informative. We should be a little bit more cautious about those models, and I think policymakers need to be cautious about the models. They should be skeptical going in, only looking at short-term forecasts of exponential processes. Of course, we also need to improve epidemiological models, which I think is a longer-term project. Okay, so now we're finally at the lockdown. All right, so as I mentioned, everybody knows that the lockdown was declared in March. It's unclear exactly why that decision was made. Some people have conjectured, some modelers have advertised that it's because of their models. Other people justified it as, well, look, you had to take some action in order to make sure India was prepared. That's a very common reaction that you see across the world. Hey, buy yourself some time, flatten the curve, et cetera. look, I will tell you that having spent a lot of time looking at the literature on this, I'm not sure that the benefits of lockdown were all that great. It's unclear. Look, Sam Asher's here, and so is Radhika Jain, and they both did work for, indirectly for the Indian government, trying to understand how to, for states in particular, not the central government, trying to figure out what the here in the back of the room, how good our hospital data. Our hospital data is not that great to begin with going into the pandemic. We had two major data sets. They weren't very well correlated, so it's hard to figure out if either of them are reliable. It's very hard to update them now, so we don't know if, in fact, we built a lot of hospital capacity or segregated capacity into COVID, non-COVID hospitals to avoid hospital-acquired infections. So it's very hard to evaluate whether or not we were actually good at preparing during the pandemic. The other thing is that you might ask, well, hold on a second, did we actually slow cases? And if you look at the cases, and then you look at lockdowns, the top figure is cases over time. I've highlighted in gray when the lockdown was. The bottom one gives you, in the dash black line, is giving you your lockdown measures, how severe they were. And the colored lines are giving you Google mobility, okay? One of the things that immediately pops out is, hey, the argument in favor of lockdown is the cases didn't rise until after lockdown ends. Just put aside the question of why we ended lockdown then. We could have kept it on going for longer if we thought that was effective. But the problem is, look at the gap between when the lockdown occurs and when the cases peak. So it becomes a little bit harder to make that decision. It's also the case that this is very naive. You want to think about the counterfactual of what would have happened if, in fact, there was no lockdown, there was voluntary social distancing. Now, one of the nice things you can rely on is you'll find that, in fact, this practice of doing a lockdown very early, March, April, May 2020, is common across countries. It's very, very remarkable, I think, that happened. And I think the most credible work on this is done in the United States. In the United States, the evidence that tries to control for voluntary social distancing in a number of different ways doesn't find massive impacts of lockdowns. So they can explain maybe 15 to 20% of the reduction in economic activity and cases. And so that makes you think that, well, that's probably also true in India. So at least I wonder whether or not there's big benefits here. Then you got to think about what the costs are. And there, we can use economic surveillance. So I'm using CPHS, so this is Consumer Pyramids Household Survey from Center for Monitoring Indian Economy. It's a fantastic data set because it's longitudinal, it's representative. It continues, although switches during lockdown to a phone survey, but continues through the pandemic. Unfortunately, there's no government analog to it, so I didn't have a lot of other sources to go to. But we see that there was massive economic cost of the lockdown. You saw poverty rates in the top graph spike dramatically. So this is the World Bank's $1.90 a day numbers. Starts, say in rural areas around 10%. There are debates about exactly whether that's the right number. But in any case, it's very hard to argue with the fact that it spiked to close to 50% just during the lockdown period. It does come down, but lockdown was pretty bad. If you look at inequality, which I put on the bottom graph from a paper that I did with Arpit Gupta and Bartek Woda, and here we're measuring inequality by the indexed income of the fourth quartile minus the first quartile, or actually it's 1 minus 4. So higher numbers means lower inequality, and you find that a lot of the gains that we made in reducing inequality since 2018 were reversed just during the pandemic. So there are big costs here, I think. And there's some lessons from this. First is, again, use narrower suppression tools. You'd minimize the cost and maybe get the same amount of epidemiological benefit. A second one is we really need to have better facility censuses and capacity censuses in order to understand whether or not governments are actually taking good advantage of the lockdown. In fact, the government would benefit too to know that, are there orders to either segregate facilities or build more beds, et cetera, are actually being followed. And the last thing I would say is that it would be really nice to have both government and private data to track economic activity. Right now, we only have economic data that people criticize the CPHS for a number of reasons, the way they do sampling. I think a good answer to that is to have independent data sets, whether in the private sector or the public sector, to do that. We just don't have that. Okay. So now I want to talk about post-lockdown surveillance. Here I'll bring up serological surveillance. So after the lockdown, you see a shift in the surveillance from just purely antigenic to also including antibody surveillance, so serological surveillance. Why did that happen? Well, the government really didn't restrict serological testing because it wasn't relevant for diagnostics, so they didn't feel the need to limit it to hospitals. Another reason we did it is because, as I told you before, viral testing doesn't show immunity, which tells us about a future risk, whereas serology at least arguably does for a short period of time. The problem was, even though the government didn't really formally stop us, there was a bunch of obstacles that were put in the way of serological testing. First is ICMR was very slow to approve rapid tests for serology or to certify private labs to do in-facility tests, whether it's ELISA or CLIA. Then the government CBIC maintained tariffs on imported tests, which was shocking because they wanted to foster the creation of domestic industry in testing, and that makes no sense when there is no domestic industry in testing. The first tests that came in are just licensed versions of Korean tests. So that was a little bit problematic. On top of that, if you try to do serological testing, I did a lot of it, it's just hard to get representative samples, and the government doesn't facilitate that. They do a census list, they do census, they have census-based listings. They could provide us representative samples to do private surveys, and they didn't, so we had to create our own. Okay. What are some of the lessons that we learned from the serological testing? First is, the most important one, serological testing is inexpensive. We did over 130,000 such tests on representative populations that represent at least 150 million people in India across a number of states, so in Maharashtra, Mumbai, Karnataka, also in Bangalore, and then also in Tamil Nadu. And those tests were very inexpensive. So roughly for a crore, you could do the Mumbai serological study or the Karnataka serological study that went all the way around the state. What did we learn from these? We learned that the pandemic spread quickly and in the community. So our Mumbai study showed that 57% of Mumbai slums were serologically positive as of July 2020, suggesting maybe the lockdown accelerated spread rather than slow spread in slums. We found that the next month, Karnataka had 46% seropositivity. Again, very quick spread. We also found that the best predictor of spread was not demographics. Remember, this is different than deaths. This is actually spread. The best predictor was density. Again, the slums data is what I'd point out to you. But also in the Tamil Nadu study that we did and the Karnataka study, roughly, or at least the beginning of the pandemic, rural areas had 10 percentage points lower seropositivity than urban areas. We also learned that antibodies measure immunity from all causes. So one of the biggest drivers as we continued serological testing was we found, at the beginning, infections were driving serology. So these are the results from Tamil Nadu up here. But infections driving, but later in the pandemic, actually vaccination was driving seropositivity because that's the point of vaccination. It's supposed to trigger your own immunity, which is measured by level of antibodies you had in your system. And so it's very important if your goal is to track actual infections, it's hard to do that with serology. The last thing I'd say is that antibodies are only a medium-term measure of immunity, and the reason is because the body clears antibodies. One real salient piece of information or fact that proves this is that between November, December 2020 to April 2021, seropositivity in Tamil Nadu fell from 30% to 20% roughly, and that's because antibodies decline. So if we want to measure long-term immunity, especially as we get further and further out, we want to think about measuring cellular immunity, which we've also been able to do. Okay, so I'll quickly go through this so I can get to death data, which is, I think, something that people are very interested in, is that we should embrace serological testing earlier in a pandemic to get population-level immunity, and we should eliminate a lot of the barriers that I listed on testing, including making representative populations available for people to do private serological surveys, which, we found, if somebody like me from the outside can do this on 130,000 people, the capacity to do this is there. We just have to make it happen faster. Okay. This may be my last statement, is official statistics likely underestimate mortality. So as everybody knows, we're roughly around 500,000 official deaths. Why do we think that that's an underestimate? Well, there's a limited number of tests. You don't want to spend them on cadavers. You want to spend them on live people. It's also the case that high mortality rates make the government look bad. Looks like they really haven't controlled the pandemic, and that's something to think about. Excess death numbers which came from a range of sources, and we have one of these papers, but I think I would point you to work by Rukmini and work by Prabhat Jha that came out in Science also, is excess death numbers around 5 million people, much, much higher, 10x. Now, the one criticism of excess deaths, which we should think about, is that it includes both direct and indirect deaths, so deaths that happen during the pandemic that wouldn't happen otherwise but are not COVID deaths, which can happen. So we might overestimate direct deaths, which is relevant. Also, excess death estimates depend on baseline. Now, we're trying to correct that, by the way, by doing verbal autopsies on a representative panel of deaths for the last 5 years, and so we'll hopefully have more better estimates of this, but excess deaths might be a little bit too high. There's also IFR, infection fatality rate estimates that suggest that the implied IFRs from the 500,000 number are too low. Sam and Becky Kai, Paul Novosad, and among others have done work showing that, in fact, death rates are quite high if you use excess death numbers. I was also involved in a paper with Andrew Levin that did a systematic survey across low and middle income countries and found that basically more IFR rates are double, closer to what you would get from excess death data than you would from official statistics. So what should we do? Well, we should probably make death registry data available promptly so we can do excess death calculations. The Indian government does this with the sampler, the SRS, and we should make that available more promptly, not after a 2-year delay. We should also do verbal autopsies on represented populations. We should do that in peacetime as well. Okay, I'm going to skip how the economy adapted because I'm running out of time. There's quite there, but let me just leave you with a summary of policy recommendations that I think we can get from the experience that we had during the pandemic to help us prepare. A lot of them are going to be prepping for data gathering in peacetime so that it's easier during a pandemic. A lot of it's going to be about changing the way we do crisis time data gathering, but a substantial amount is about interpretation. We really should be, we've learned now, we've had one pandemic. That was our batting practice, sadly. So we should now, next time we see a major pandemic come through, we have no excuse for not performing better. Thank you.
I don't have the camera. Who's? Sonali, you're next, right?
I think
no,
Shamika.
Shamika is next. Okay, sorry. I didn't have the schedule here.
Thank you. So good afternoon, everyone. Thank you for the opportunity. Well, it is a very comprehensive paper, quite exhaustive. So I'm going to focus on certain aspects of the paper which spoke to me. This does seem like it's a very extensive literature review, and yet there are a lot of assertions and sort of pronouncements which, in a hindsight, now we've all had the benefit, and we might say we're at the end of a pandemic, and yet some of us will touch wood, because we're really trying to model tail events. And tail events, for those of you who model, tail events usually get very low weights, which makes the forecast very difficult. So now the paper starts by saying, how could India have detected COVID earlier? Foreign surveillance, and yet we know what the situation with data forthcoming from not just China, but also WHO with regard to declaration of a global pandemic, how that came about. It was only on March 11th of 2020 when the WHO did declare a global pandemic. And by then, India already had about 65 cases across states, mostly on the Western industrialized connected parts. Now, did India act immediately when they received evidence of outbreak? And the paper asserts, no, India did not act until cases reached its shore. That exclamation mark really is because I don't know where this assertion is coming from vis-a-vis, let's say, what was the number of cases in other comparable countries to make a statement like that perhaps more could have been done, whether India could have done more even before the infection did come to its shores. In fact, we are told governments were warned about COVID. We are being told Bill Gates has been warning for years. Well, that is true. We have been warned about pandemics since 1940s. That, to me, I think, speaks more about what the NCDC is doing. It gets into the details of the institutional capacity whether NCDC even has the capacity to follow up on a lot of those things. But these are really generics. When we get into specific policy initiatives and policy implementations, like travel restrictions, quarantines, lockdowns, we are told travel restrictions are of limited value in controlling the pandemic, and yet we aren't really provided with any specific evidence as to why that is so. Similarly, for quarantines, that it deters testing and it doesn't work. Yes, I quite understand, as we all do in this room, what the theory behind it would be. But what does the evidence tell us? What does the data tell us? How many reported cases before countries announce lockdown? Is there something like an optimum testing? As Surjit mentioned in the beginning, many policy recommendations were such that the sooner countries reacted and responded in the form of lockdowns or otherwise, the better it was for them. In fact, many within the government argue that it was a preemptive lockdown because we just didn't have the infrastructure and we needed the time. So obviously it wasn't meant to stop the infection, it was meant to slow it down. Now the reality of it is that there were at least 7 states in the union which did not have a single ICMR approved testing laboratory. So you will then appreciate what getting that kind of additional time means. But going back to, again, the research of it, is there something like an optimal number? Next time round, 500 was perhaps too low. And yet, I think a lot of this analysis is of the nature that hindsight is indeed 20/20, and yet the problem is that of forecasting and making future predictions. The claim in the paper is the CPHS data shows the mean and the median income fell before the national lockdown. Yes, we see that in the data. But remember, there were a series of steps taken before the national lockdown. In fact, national lockdown was around the 24th of March. But the Epidemics and the Disease Act was invoked by most states of the Union very early on in March. In fact, travel restrictions were invoked very early on. So it's not 0-1, it's not a neat experiment in that nature. There is a sequence of staggered events which are unfolding state after state, and they all affect the final outcome. Now, the lockdowns did not avoid infections. Yes, that was not the goal. The aim was, as was repeatedly told, we were told that the goal was to slow down. Lockdowns may have accelerated infections in cities. Well, was it lockdown or was it the density? Again, there has to be careful analysis with regard to that. When we move to the modeling part of it, the part that I really like is the part we've all been sort of, as economists, working on these set of issues. We're not modelers, we're not epidemiologists. But we have been looking at certain blind spots as far as the epi models are concerned, and I think the human behavior part is a very big gap in the epi models. The assumption that human behavior is unaffected by the occurrence of an epidemic is quite naive. Very clearly, if you look at the global mobility data, and this is something we mapped for most states of India, what you see in the beginning is, of course, there is national lockdown, but what you see in the second wave, when you see the big decline in that's about April or so, there was no national lockdown, number one. Number two, states did not introduce or invoke any kind of restrictive act at the same time. In fact, there was a staggering in some sense. Many states invoked no restrictions or no suppression strategy at all. And yet what you find is in the beginning of the second wave, people stopped moving around. So yes, human behavior does get affected. People are responding rationally to the infection, whether you have a lockdown or not. So this, I think, is a very important contribution of the paper and one that I quite like. Now, the disease modeling and forecast, and I think this is where we all have to be extremely humble, that the modelers were, in fact, forecasting quite regularly. And the government, I don't know whether they were listening. I mean, I can't speak for the government. It's so difficult. We must wait for the government to talk for themselves. But we do know that regular updates of parameters and forecasts were made available publicly. And Anup talks about the group from Michigan. And yet this is what we know as the fag end of the second wave, which was quite debilitating. When Dr. Mukherjee and her team told us that if the government had declared a moderate lockdown, this is in the beginning of the second wave, daily cases would have peaked at 20,000, or perhaps around 49,000 max, instead of touching 414,000, which was the actual case around then. So this is now July of 2021. The problem with modeling is it is exactly the same group that told us exactly 4 months back that India has a human barricade, which is going to keep the cases under control. In fact, the same group told us that there is a human barricade for the virus. By the end of March, we would see a very slow, steady decline in cases. The same team, and this is now Ramanan's team, which basically said India has suffered a lot. And because it has suffered through a lot, it's reached the other shore now. I don't see the prospect of a second wave in India. If it does happen, it is likely to be a modest one. And this, by all of you know how bad the second wave was. Now, what exactly is happening around the same time that these proclamations by forecasters and modelers, when they are making this claim, for those of us who are actually looking at the data on the ground, what do we find? As of 9th of February, India had already started to report positive net growth of daily active cases. So if you didn't have a very sophisticated model, but you were only just looking at the daily cases and looking at nothing but just the 7-day moving average or the 10-day moving average, you would have seen that the second wave had indeed begun. Moving on, people trying to model tail events, and this is why I'm saying that the problem is we have to be humble because we are really trying to model tail events. And when you model tail events, the weights are obviously very low. We know that. So using past data to predict the future is hugely problematic. The modelers have come out and they have been proven wrong again and again and again. Now, this is not to single out these specific modelers. There were many modelers, including scholars within India, particularly from computer science, from IIT Kanpur, etc., who did get a lot of their forecasts wrong. And the problem is really about overfitting the data, overfitting the model with the data. The predictions are completely problematic. Data availability being sparse is, of course, a very large part of the problem. Now I move to the excess death part, because that's a part that I have been writing on. Now the excess death part is a bit messy, because I think we're gravitating towards a situation where we're basically saying we just don't know. And I think for policymakers and media and people at large, while it is a difficult thing to accept and acknowledge that, look, we just don't know, for a room full of scholars, I think you will appreciate better that the problem with the data systems in India is that it's very difficult to estimate something like an excess death. For instance, even the WHO team, led by Wakefield et al., they use local area estimates. Why is that? Because data is available for some parts of the country and data is not available for other parts. So when that happens, they basically make proportionality assumption. And there is a huge problem with proportionality assumption, and I'll show you in a minute. Because migration makes this whole situation extremely problematic. It's not stable. The proportionality that they're assuming doesn't stay stable over time. In fact, the other concerns are, we are talking about India, which does not have a robust CRVS. We've been writing for it for the last 10 years. We've been trying to work towards enabling a robust CRVS, but a country like Germany and Sweden, and the German case I know a little better, the German results, in fact, when the modelers went back to the table, they not only admitted the errors, but they revised their estimates, basically saying that the spline function that they were using to make the counterfactual calculations were indeed, is highly sensitive to what the spline function is. So they did go back and revise those estimates. Now imagine that is an OECD country with a robust CRVS system. Now in the Indian case, it is a lot of guesstimates. Now the WHO study, the same study, in fact, they have already revised the standard errors of the Indian estimates 3 times. And that is the last counting. I stopped counting some time back. So the models are clearly making assumptions which need to be scrutinized. Now for the benefit of the room, let me just tell you, we don't count every death in India. This is the reality of India's death data. The top red line is the SRS data. SRS is basically sample registration. So we don't count every death, we estimate the death through samples. So the SRS you can see is relatively flat because it's an estimate, and this is up to 2019. The bottom line, which is a rising trend, is the CRS, that is the civil registration of vital statistics. And that you can clearly see has a rising trend because we are registering more and more deaths. There is just a greater emphasis towards registration. There is a greater emphasis towards HMIS and getting these kind of institutional deaths, etc., registered. So you can clearly see that all estimates that exist in the market today, which only look at the CRS, and believe me, there are quite a few. If you just look at the past 5 years and you forecast the next number, naturally that trend will give you excess death. In fact, the work by Arvind Subramaniam basically suggested that there were excess deaths. If you looked at that estimate, there were excess deaths of over 1.5 million in 2019. This is before the pandemic. So there is clearly a problem with that. Now, it isn't just as simple as that. It gets a lot messier. What is the mess? This tells you the level of registration over time. What is level of registration? The number of deaths that are registered divided by the estimated number of deaths. So what is the proportion of deaths that are registered in a state? They vary a great deal. If you look at Andhra Pradesh, look at Assam. Assam has about 80% level of registration of deaths. And if you look at Delhi, it is 250%. In fact, if you look at Chandigarh, and I haven't put the data there, Chandigarh is 460%. What does that even mean? Well, it tells you this is a bit like the streetlight effect. People migrate to cities for healthcare. And unfortunately, you are going to see lots of deaths and hence lots of registration in cities. You are going to see a systematic bias of registration and deaths in areas where you have healthcare. So the big cities, and you can clearly see MP is about 90%, Kerala is around 110%, Maharashtra has just hit 100, so on. So there is a systematic variation. So the assumption that I just explained, the proportionality assumption, or in the previous case when I was talking about the local area estimates, there is a huge problem if you assume that that stays constant across places. And I'll finally end here, my time is up, that in fact there's a fantastic paper, unfortunately completely ignored by people who are interested in estimating excess death, by C. Rao, which came out in the BMJ, 2020. What does he tell you? That even the CRS has systematic errors. In fact, he showed that the CRS data on deaths undercounted the number of deaths by 2.28 million. This is when the deaths were 7.6 million. So you have serious case of undercounting even in 2019. And that's an excellent paper, and I suggest you read it if you're interested. The sea water data, which Prabhat Jha, etc. look at, has serious issues. And we have written extensively about those are large surveys which are meant to pick up governance and perception issues. Again, picking up death, low probability tail events with this kind of sampling leads to all kinds of errors. And then there are a series of, in fact, I only went up to 2018, but we've been writing on excess death for the last 10 years or so. So on the whole, very comprehensive work, but I think if we want policymakers to take us seriously, then we will have to get down and dirty with the data. We will have to look at exactly what is the nature of the current data systems in India, and we will have to think of exactly what that means. And sometimes the answer might just be that we don't know. Thank you.
Perfect time. Sonali?
Is the mic on here? Okay, great. There is an American serial that I was addicted to, West Wing. It has this Nobel Prize-winning economist who becomes the US president, and it had a tagline, which I used to love. The economists were put on earth to make astrologers look good. I think Shamika has convinced me that epidemiologists were put on earth to make economists look good. Okay? So I think we all need to deal with all the predictions and estimates with a level of humility, particularly during a period when the data were difficult to come by. Okay? I think Anup Malani does actually a very interesting job. He sort of goes through a variety of ways, variety of steps at which the data were used for modeling within the COVID pandemic. And he sort of estimates, what worked, what didn't work, what kind of data we need, and so on. So I think what I'd like to do is sort of focus not so much on what the paper said as much as what he recommended in terms of future going forward, what we need. I see as Anup is making 4 different recommendations. 1, the forecasting models need to improve. 2, in order to improve our models, we need better data. We should encourage collection of better data from both governments and individuals. And he mentioned some very interesting data collection efforts that he was involved in, collecting seroprevalence data in several different states. He also notes that we should increase the incentives for individuals to get tested so that our COVID prevalence data is based on representative samples. I honestly don't know how you can encourage anybody to get tested in a social situation where testing positive had a lot of negative implications for individuals. And he argues that governments need to stop being secretive and controlling and let diverse groups work, let the data be publicly available, and trust in people not to create a panic. And finally, we should link economic data to disease surveillance. Everything sounds fantastic, okay? As a researcher, I don't think I could lay out a better research agenda. Perhaps, I guess I would add a little bit about getting some behavioral data so that we can do better agent-based modeling, okay? But in spite of the fact that this paper makes my researcher's heart palpitate with great pleasure, okay? I'm not sure that we are offering the policymakers sufficient guidance on preparing for the next wave of pandemic, okay? Even when it comes to just data, okay? Almost certainly, when there is a next pandemic, okay, R0 is going to be different from what we see for SARS-CoV-2. It's quite possible that it will affect different age groups and different sections of populations. It's quite possible that it may be more virulent or less virulent, and that antibodies might last longer or lower time, okay? So given that, our ability to use the present experience for handling future pandemics is about as useful as the experience of Spanish flu was to the COVID-19, okay? So in some sense, I think we need to think about what is rational and realistic given the current circumstances in terms of what we can recommend for future. Before I get into it, though, let me just also talk a little bit about Anup Malani's favorite method, seroprevalence surveys. Okay? Actually, seroprevalence surveys themselves were not particularly useful in predicting the Delta wave. Okay? Seroprevalence surveys would have told us that a large proportion of population was already infected, and hence the Delta wave shouldn't have happened. There are a couple of very interesting studies to cite. One was, there was a study in Delhi in January of 2021, where they randomly selected 100 individuals from each ward and had a sample of 28,000 people. It had a seroprevalence rate of roughly about 51%. Okay? And yet, within 3 months, Delhi was in the grips of the Delta wave. You might say, well, 51% is not herd immunity. But there are interesting studies coming out of Brazil where when they did seroprevalence studies, the seroprevalence antibody rate was roughly about 76%. And yet, and this was only about 3 months before the second wave hit Brazil. Okay? So I don't know that seroprevalence studies did much good in terms of, it told us what was the past experience. But given that virus mutates, antibodies decline, it didn't turn out to be nearly as useful for predicting the future outcome as we would have liked it to be. So what can we do? I mean, clearly, look, we are living in a world where we do want to think about what we can do in future should such a calamity strike again. Okay? We need to make some rational decisions. And yet we know that we are living in an imperfect world where we can only get certain amount of information. It seems to me that there are 3 or 4 lessons we should be probably taking out. One is that I think early warning of potential threat is useful. Granted, this time early warning was clouded in a lot of politics between WHO and China and so on. Exactly. And I would also note that India was actually unwilling to necessarily buy into some of the external experiences. Even today, when it comes to sort of vaccination for young children, we don't really want to always use the experiments or testing that has been done, trials that have been done in other countries. Okay? But I think we do need to put together an area in some ways of sharing information. Given that India is going to be president of G20, putting in place some sort of a collaborative data sharing agreement for scientist to scientist without having institutions like WHO mediate would be something very sensible for us to do, so that at least we can get some early warning, we can learn something from other countries' experiences. A good example is actually what we learned out of the UK experience on vaccination, when based on that experience, we decided that we would extend the period between first and the second dose of vaccine. When vaccines were in short supply, we used it to make sure that the maximum number of people got covered by extending the period between the two vaccines. So, sensibility, finding some way of international collaboration and getting better data would be a useful thing to do. Second thing I think is that we went into a singular focus on prevention rather than management. I think our COVID-19 prevention strategy in some ways was built on our mindset around HIV/AIDS. With HIV/AIDS, the focus has always been on prevention and through behavioral modification. And we kind of went through that mindset that, okay, we need to prevent the spread of the disease. Okay? There is nothing wrong with it, okay? But we did not focus on management of disease if it happened. Okay? Again, sort of following on Anup Malani's footsteps of focusing on data and planning, I think what is needed is also sort of thinking through of managing hospital resources, ventilators, people resources, etc., putting in place better management systems. Again, the current government seems to be in love with wonderful HIMS and various sort of management systems. Perhaps those would be a good place to be investing some time in, so that should there be any kind of a pandemic or earthquake or flooding, okay, we would know where our resources are and how to manage them. Third area, I think, is we need to develop processes for delivering welfare benefits more quickly than we have. Currently, what happened was that we were looking for the keys under the lamplight, and so the benefits were given to people who were part of registries, Jan-Dhan accounts, PM Kisan, and PDS subsidies to people who already had ration cards. Okay? We somehow need to be, and those were not necessarily the most affected people. Okay? This is how we missed the migrants. The benefit focus was sort of on the rural areas when the pandemic was much greater in urban areas. So developing some sort of a system by which the welfare benefits, both in cash and kind, can be delivered quickly would be very useful. Social registries have their own challenges. There are issues regarding privacy. You do need some sort of a voluntary registration. But I believe that the world today is very different from the world we had 4 years ago when there was a strong opposition to Aadhaar-based registries. So thinking about some sort of registries that would allow us to deliver welfare benefits quickly and to the group that is most affected would be very useful. Okay? Finally, I think that we do need a sophisticated decision matrix for identifying the potential risks and benefits and then sort of implementing our policies. I think one of the most interesting example is around school closures. Okay? India had the longest, one of the longest school closures in the world, even in South Asia. Okay? Delhi schools have barely opened a few months ago. Okay? The school closures had obviously tremendous impact on learning losses. Now the decision matrix that went into it was, basically, yes, we all know that there is going to be educational negative impact, but perhaps what we are doing is protecting children from exposure to the disease. The question is, did we really do that? Okay? Counterfactuals are not available. There is no way to know. But an interesting example is what happened in Sweden. In Sweden, the online education was given to the upper secondary school students, and in-person education was given to the lower secondary school students. And some of the economists have done some fairly interesting analysis that came out in PNAS. And what they found was that, and they did not test children, by the way, they only tested parents, but the idea was that if children were infected, so would be the parents, okay? And what they found was that basically parental infectivity rate was pretty much the same whether they had children in lower secondary school or upper secondary school. And the study did fairly nice matching. So it seems a reasonably reliable study. So clearly, parents were getting infected from a variety of other sources, and presumably so were their children. So the school closure was not delivering the kind of health benefits that we would have hoped it would. What it did do was it reduced the infectivity among the secondary school teachers. Lower secondary school teachers had higher infectivity than the upper secondary school teachers who were able to teach online. But then that kind of brings for the question of the essential workers. See, a variety of people in a variety of occupations, people acquired infections, not just the healthcare providers, but Amazon workers, taxi drivers, postal carriers, a variety of other people who were in a job where they had a lot of people-to-people interaction. So I guess it would be helpful is to examine some of the decisions that we made in the past, look at its impact on sort of ethically, what would we want to see, what should have been done, how would we have gone about making better decisions, and develop some sort of an understanding of future, how will we react to any other pandemic that might come in a very different way. Okay? I think there is a lot to be learned out of the present pandemic, but I'm not sure that it is necessarily the kind of lessons that we were getting out of some of the discussion that Professor Malani made. I would like to see us focus on some of the longer term and more deeper issues on public policy. Thank you.
Thank you very much. I'm glad everybody is being fully on time, so I will now open the floor for comments, etc. We have 30 minutes, right? Is that 30 minutes for discussion? And then Ruchi. And
Okay.
no.
Okay, thank you. Well, first off, a fascinating paper and very valuable paper, and I congratulate the author. Secondly, I think the discussion is interesting, and of course, it's an important topic. I, of course, am not in the field, so I'm way out of it. I've done no research on it except to read in the newspaper and see a couple of cartoons, some of which have been valuable even. But in any event, I have had something to do with deciding on research issues. And one of the important questions one has to think about, in my view, in research, is on the one hand, we have to act now. What do we act on? We act on what we know. As we do that, we ask, what do we need to know to make it better? And obviously, when COVID hit, everybody wanted to know everything, and there were no data, except for past plagues, which of course have been different. And there was some received knowledge in healthcare and stuff, but there wasn't much. And I think that some of the papers that are cited quite clearly needed further research, and I think the calls for further research are not only clearly warranted, they're mandatory. If not, you're not doing the research. But I think that calling all the attention of everybody to the shortcomings of existing papers, instead of saying, look, here's all we knew now, here's what we need to know, sends the wrong message in terms of public information and things that are terribly important. And I sometimes think that some of us, and this is more general than COVID, it's on everything. It's the Ukrainian economy, you name it. It's an issue that sometimes the criticisms, when they come public, if they're not somehow couched in this notion that we need to know more, and this is all we could do because we only have 6 months data, sometimes end up leaving the public more skeptical and become an obstacle to good research and what goes after it. So in a way, I would urge all of us to be careful as we say, here's what we need more research on, to make clear that then we can do it better. But if today we do not act on the best information we have, we're making a decision not to act. And we're doing it not on the basis of research, but just doing it on the basis because not making a decision to do something is a decision not to do it. And if we don't have the information, and we say whenever we don't have the information, we won't do anything, That's paralysis. So I would urge being careful in these kinds of others. I've read some of this stuff in the papers and what have you, and some of the stuff comes through very negative. And yet, this is the best we now know, and researchers are going to take that and they're going to see many of the things some of the suggestions that you made as to further research. And in some sense, we hope that people will spot where the big payoff for research is so we can get there faster. But let's not confuse and criticize the authorities for doing the best they could based on limited knowledge. Now, I had a couple of other more minor points that I wanted to make. You mentioned getting more collaborative data, and I fully agree. But that's what the World Health Organization was doing beautifully. It could have done it better, and we could all do better on everything. But it was doing better, and it was an effective organization until about 2014, when some governments, and I won't name them, began not being as cooperative as they could have been or should have been, the result of which is, I would argue, the policy lesson for the moment for the researchers who want data is let's at least mention that the WHO, I'm sorry, I'm from trade policy, so I give you the wrong, never mind. Anyway, give you, sort of give the boost to getting the WHO back where it should be in terms of data collaboration and so forth. And by the way, the United States has been at least more guilty even than India on this, which in these matters is sometimes unusual. I think many of the suggestions for future studies were very good. I don't have enough knowledge even to decide which are the best and the most important things to know, given what we can feasibly know and what will give payoff soon enough and all that. But I think these are very helpful papers, so congratulations.
Vijay?
Thank you for the great discussion. I just join in congratulating the authors and discussants. Actually, this is an area which I'm paid for. So last session, my discussion was a job that so I'm the head of the IMF's Pandemic Response Task Force. So I wanted to make 3 policy points and issues for the research agenda. One is a backward-looking point. The Delta wave peak of cases in India was 400,000 cases, I think on May 7th or so. But about 4 to 6 weeks before that, cases were rapidly rising already in Maharashtra. And it was exactly as Dr. Ravi mentioned, that was quite well understood. I think it would be a great case study to bring together academics and the government officials to understand what didn't work well and how can we do better the next time. Because that does not require modeling, that just required looking and coordinating across the state. So that's point 1. 2 forward-looking points. First is, COVID is going to be with us forever, and in India, the impact of COVID is going to be with us forever, exactly as Dr. Desai talked about the long-term school effects. I would like to put also on the agenda effects of long COVID. It's important for us to understand, especially in India, what that means for, given the high seroprevalence, what will it mean, what are the long-term effects on health? And that I want to put on the research. And then lastly, COVID will not be the last pandemic. And I wonder, this is an opportunity, exactly as Dr. Desai has said, for us to build a health system strengthening agenda at the local level that is coordinated at the national level, based on the lessons of COVID, such that when the next pandemic happens, whatever the nature of the pathogen, we can do better based on the lessons we've learned now that we hand over to the next generation. So thank you.
Devesh?
Just 2 points. One is, last year the Supreme Court had announced that everyone who died of COVID would get a cash payment. Has anyone looked at that data on how many people made claims to get this money? Because they would have to give the sort of details of the death and so on. Because that might give us an alternative source of data, because clearly there's an incentive for people to claim the money. So, they might overclaim and some people might not know about it. So you would underclaim, but the 2 might cancel out. But at least that is an additional source of data. I haven't seen any work, and I was wondering if any of you had seen or anyone had used that data. The second point is that, whenever something like this, like COVID happens, the usual, not entirely, but the main attention is on the national government. But we know that public health constitutionally is a state subject. And what did this tell us about how much states prioritize public health? So one way to see it is if we look at state budgets in the most recent year, is there any difference in public health spending from the meager? Now, the way I've looked at it, I haven't seen evidence, but I was wondering if any of you had done work. And what does it tell us? Because if it is constitutionally a state subject and we repeatedly go back and ask what the central government is doing, we are looking at the wrong place. Because that is where the action sort of ought to be, and that's where we should sort of look at much more.
Okay, I want to give the author and discussants to answer if they feel like answering anything now, and then go to the next round of questions.
I'd be happy to answer it. Should I confine it to this or also talk about the commentators?
Yeah.
Okay. Okay, so a few things. I think I should be a little bit more clear about kind of the broad lessons, because I think what comes across as criticisms, actually, I just have to say I just agree with, because that was the point of the paper. So let me try to reiterate that so that you know what it is that I'm saying. The first thing I'm saying is that when you go into a pandemic, the mindset that you take to responding is critical, and we shouldn't always take the mindset of a treating doctor. We should think about how public health officials would respond, and maybe not even limited to that. Think about broadly like a statistician or an economist. I think these are different perspectives that can add to our understanding of what the threat actually is. So that's number one. Number two is make fewer assumptions, both in your models and in your testing. In fact, one of the things that I've learned through doing testing, doing antigenic testing, then serological testing, then cellular testing, even trying sequencing, is that you need all of them. And you need to interpret them correctly, though. So there are times when serological testing is going to be good. I did a lot of it, but one of the main things I learned from it is limited amount of information that you can get from it in terms of long-term immunity. And for that, you need to do cellular immunity tests. The key thing that I took away from that is it's feasible. Somebody like me can do all these tests across this. Certainly the government can do it much better. And there are other private groups that have done it as well. So that's the second one, is make fewer assumptions in your models, do a bunch of different types of tests and learn from all of them, just interpret them correctly. The third thing is, in order to do that, you need to build capacity in peacetime. And I think we all agree on that. So Shamika talked about CRS and insulin inadequacies, 100% agree. Doing SRS faster, I think we would 100% agree. I think the one thing that I would add is, hey, why don't we do verbal autopsies to address some of these problems? So just have a representative sample of people that we come back from. Maybe we can take it from the same methodology as SRS or do it privately, and then do verbal autopsies. What are those? You go to households after there's been death and ask the next of kin. This is a WHO-sanctioned technique. And then you can map those narratives onto ICD-10 codes, and you can figure out not just all-cause deaths, which is what SRS and CRS tells us, but you would also learn about cause of death, which is super important for general health planning. So agree with that. So that's item number 3. Build capacity in peacetime. Fourth is think about incentives. So WHO, why did it have problems? It wasn't because the WHO had problems, it's because countries did not want to cooperate with the WHO. And that particularly happened in places where there are a lot of disease, where they no longer needed WHO cooperation in order to be able to handle the disease on their own. I'll let you decide which countries I'm talking about. And as a result, you saw a lot less cooperation. And that's a general thing that we've seen. So I've had a few papers where we documented where incentives to report diseases are mitigated because you knew there were sanctions if you reported those diseases. So we'd learn about outbreaks late. Now, is that going to change? Unlikely. But what it does mean is that we should plan on that occurring next time around when we think, are we going to get an early warning? Probably not going to get an early warning, okay? Another thing is, why did India respond late? I think it's quite rational for India to respond late. Almost every country responded late on average, and the reason is because they get 100 different threat assessments for 100 different causes, and they have to decide which ones to spend a limited budget on. And for good or for bad, we often do this by looking for the first signs of damage, and then we start acting. Now, is that going to change? Probably not, but we should think about that. We're unlikely to get foreign service or surveillance. We're likely to act a little bit later, and we should think about that when doing so. I think the same thing about testing. I don't have a great RCT on do quarantines discourage testing, but there's a lot of qualitative evidence, and we can even look to our own behavior about whether or not we test and see whether or not we're motivated by what the consequences of the test results are. And I think that's something we've learned, and we should probably expect to happen again. The last thing is, I think we all agree, we should have policy respond, just to be very clear, I think the most important thing that Sonali said is don't make assumptions. So I want to make sure that was very clear in that when I said we do a lot of tests. But the last thing I want to do is connect. We learn a lot during the pandemic, but policy was remarkably rigid. We didn't change what we were doing, even as we learned things. And we really, I think, at the end of the day, have to think about why that is. And I think what's really important about this is, and so here I agree with Anne, look, policymakers aren't always, they're not, they often act in the public interest, but the problem is they face asymmetric information because they have a bunch of experts telling them different things, and they're not experts, so they don't know which expert to trust. We saw this in Illinois. J.B. Pritzker is getting advice from lots of different people. They all look really good, but they're different pieces of advice, so how does he pick? Sadly, when you're faced with that sort of situation, maybe you pick on politics because otherwise you don't have an expertise to choose between them. And I think we should expect that going forward. We have to figure out a way, and I don't have an answer to this. How do you solve that asymmetric information problem? But we have to be realistic about it. Even good-natured or good-intentioned politician will do this. Now, on specific issues, I want to be clear about a few things. So first, let me work backwards. So Deveshish, let me say I don't know what states could have done different. I think they make similar mistakes as the central government. But one issue that I think came up practically was that a lot of states felt their hands were tied because the central government, and I don't mean all of it, I'm not talking about the PMO, for example, but like ICMR came up repeatedly as a real challenge for states doing stuff. Tariffs on imports, that also affected states to some extent. So I think that may be a reason, is because it required a joint response, but I don't have a great answer besides that. On the issue of the Supreme Court case, honestly, I'll say that's a great idea. Now, we have to think about how to interpret that sort of data and what'll go on. I also am tempted to say that doesn't seem like a really wise policy in hindsight, but put that aside. That wasn't your point. Beyond that, I think I would say I want to answer Sujit's first question about why lockdown. It was very frustrating for me because I worked with epidemiologists before the pandemic, and there are some kind of conventional wisdoms that they all told me about. And these are both modelers and also kind of old-fashioned epidemiologists. They said lockdowns typically don't work; they're too broad-based. They told me travel restrictions don't work. Most reasonable R0 infections get past travel restrictions. Also, travel restrictions are generally porous. We have very few places that have been able to implement them effectively. And then the pandemic occurs, and we either toss out their recommendations or they're silent about their wisdom that they've learned from earlier pandemics. And I found that a little bit disappointing. And I became a little bit cynical at the beginning of the pandemic, thinking, here's the problem. This is a situation for a group of people to have a lot of power and influence. And if they recommend some of these things, they might have a little bit less power and influence. And maybe that was the reason. Now, I think that's probably going a little bit too far. But I think one is tempted to wonder about the extent to which people were withholding, kind of holding back on some of that because they were more involved in policy when they did hold back. I also think there's a lot of political pressure to act. I mean, if you're the one, let's suppose, think about Sweden. Think about the global criticism that Sweden got for not imposing lockdowns. If you're the holdout when everybody else is imposing lockdowns, you look really bad, even if that's the right policy, or you think that's the right policy. So I think that becomes a little bit difficult. And a really great way to see this is look at the timing of states in the United States for when they impose a lockdown. It's all within a short period. They don't do anything, and then one state does it, and then every state does it. What is the probability that the spread was even across the country in that way that made sense? I don't think that was going on. I think what people were looking for is what are we supposed to do? What are we supposed to do? Oh, first state decides to do it. Now we've got cover, but we can't be the one state that holds out, right? And the ratcheting down was exactly the same way. So I think the political pressure explains a lot of it. You have to look like you're doing something. There's a lot more that I could say, but let's move on.
I'll answer Devesh's question. Devesh, I can speak for one state because I'm working with them. Madhya Pradesh has seen a 35% increase in the health budget in the last 2 years. And it is, I think, entirely because of the pandemic. And they are amongst the bottom 4 in terms of per capita income. So it is a poor state. But it was in the top 4 when it came to the vaccination drive. So I think they have somewhere realized that they have the means, at least the governance architecture through which they can get some basics right. So in fact, there is a task force which is monitoring the neonatal mortality, infant mortality, and maternal mortality, largely looking at maternal and child health. I think that whole initiative has happened thanks to the pandemic, and I think there's a growing sort of an awareness. So that is one. The second is the Ayushman Bharat, in fact, the National Health Agency. has data. So it's not really driven by the Supreme Court ruling. I'm not yet sure whether the government has accepted that ruling. I have a feeling they will contest it. It has huge fiscal implications. But I do know that data with the NHA will be able to tell us in terms of, it's an alternate and a good way to measure the death numbers in itself. But I do know that there is a good paper from IRDA, the Insurance Regulatory Development Authority, which actually looks at claims around this time. So there are some papers.
Sonal?
No, I think most of the questions have been answered. So,
Do we have any more? So we'll take 3 more questions.
Just a clarification.
Let me ask, how much time do we have?
We can take another 5 to 7 minutes.
Okay. So 3 more quick questions.
Mine is just to
Vidul,
know
and then
something.
Ram.
How exactly are you measuring the lockdowns? I mean, which is the database and what other databases exist? I mean, what we have seen is mostly people use Oxford Stringency Index, which is an awful measure because it just takes the maximum restrictions in a particular city at a point of time. It virtually gives no idea, and probably any research based on that would be completely misleading.
Ram?
Yeah. So, Anup, you argued against monopoly, of official government monopoly over disease data. And also, by implication, you argued for private ownership of the data. I did not fully grasp it, but if idea is to have private entities use and own up disease-related data, in the presence of a lot of uncertainty about how data, any given data could be read and interpreted, my feeling is that it can make governments even less receptive to what you make of that data.
Neeraj?
Just one simple point that lockdowns would have different impacts depending on whether it was in the beginning of the pandemic or at a later stage in the pandemic. It would have a different kind of we all know that this is a highly endogenous, not an exogenous policy. Public response to it, human response to it, as well as public policy response to it is not exogenous. So I think, some of the interpretation that we are making and some of the way the policy has been implemented, lockdowns, depending on what kind of lockdowns are you, is it school lockdowns, is it business lockdowns, would have a different kind of an impact. So any generalized statement about the impact of lockdown in one particular country, whether it would have the same kind of an impact in another, is probably an exaggeration.
Thanks. You have about 2 minutes?
Sure. Yeah. So on lockdowns, I agree the data is terrible, especially in India. So I think that makes it difficult to interpret the effects of lockdowns for sure. Huh? Oh. Mike, yeah. So I agree with you on lockdown data being not very high quality in India. It's very hard to figure out not just what the policies were, but also the enforcement of those policies. So I think that makes interpretation very difficult. A lot of what I say about India is also being informed by data from other countries where we sometimes have better data. So I think in the United States we have reasonable data, and so that's a little bit helpful. But I agree that I wouldn't say this is top tier journal identified analysis. But again, I think an important thing to remember here is that, look, in pandemics and in many policy environments, we're not going to have that sort of data, and we have to make some judgments. So yes, I acknowledge that data is bad, but that we still got to act, and I think that's a point that Ann had made. So the question about private data. Look, the reality is that it is true that the government could be a little bit suspicious of private data, but there's a lot of private data that we could use and learn a lot from, and I'm going to conjecture that we're going to do that a lot more going forward. Just because the data gathering mechanisms in the private sector has become more and more of a digital economy, is going to be it's going to be credible. There's going to be a lot more of that data. Government will accept it in economic policymaking, and I think over time it might actually be useful accepted in disease data. But also, when I say private, I don't mean like nefarious private. I'm also talking about academics getting together and gathering data, and that's maybe I should use the word non-governmental instead of private. On lockdown, I agree it's complicated. I actually think so. What Sujit said at the very beginning, there's this burst of data. We learned a lot about like. What is the optimal timing of lockdowns, given human behavioral response? What if there's a limited capacity to accept, like there's increasing costs with lockdowns? What's sad about that is that those people wrote those papers, and they're going to just be maybe published, maybe not published, and people aren't going to look at them. And I think that that's going to be a big loss. Now, does that mean that I can answer your question of exactly, can we know with great precision? The answer is going to be no. I think it's a hard empirical problem. But we learned a lot of intuition about what goes on, and it would be sad to ignore those lessons next time around. I think the big challenge for us is, do we learn the lessons from this lockdown? And I would go back to what Sonali said, we have to make fewer assumptions. What we learned about is that we need a lot of different types of data. We have to come up with better models. We have to be open to the fact that things are going to be different, and we have to learn in real time. I think the hardest part of this is just actually getting policymakers to change during the pandemic. So what I'd like to do is see if we can build capacity in peacetime so that we have the ability to influence those politicians a little bit better next time.
Sujit, can I take 1 moment? Sujit, can I take 1 moment?
Yeah, certainly. Sorry.
Sure.
Who's that? Oh, sorry, I didn't say. You have to put your...
Thank you. This is a comment on the discussion on counting excess mortality deaths of COVID. The estimates, a lot of estimates floating around. Different authors have proposed different estimates, number of estimates, 4 million, 5 million, 3 million, IHME, 3 million, WHO estimates, and government says, no, this is not true. The best way to get an answer or resolve this question is, I think, as you said, rightly pointed out, we have SRS data, say current count, pre-pandemic count is 8 million or whatever the count you have. You have to wait for next round of SRS data, maybe it will take another 2 years to get data for this period, 20 to 22 period. And if the SRS count comes out with mortality estimates, then we will know the correct number of excess mortality. So one way is to wait for that. The other option is that we have very good health survey platforms, the DHS equivalent of in India, for National Family Health Survey, other health survey platforms, the NSSO survey platforms. They are, very robust sampling methodology platforms, which can be used to do a quick survey to add a component of mortality, ask a couple of questions on mortality retrospective, questions on mortality in the last 2 years, and also add the component of verbal autopsy, that the WHO verbal autopsy model, which we have implemented in many of our own surveys in IIPS. So that sort of scientific survey will give a very clear, robust estimate of excess mortality. And we are demographers are good in counting all these mortality and fertility. So that's the best way you could possibly resolve this question. Thank you.
Sonal?
I wanted to respond to Ram Singh's comment. Basically, you talked about public data versus private data. I think that while I'm a big believer in private data collection and triangulating with public data, I think during the pandemic, we are dealing with a very different situation. I have a lot of colleagues who are sitting in this room who have been doing telephone surveys from NCER during the pandemic. And one of the things that happened was that it was very easy to do surveys during the first lockdown because nobody was sick. People were sitting at home. They were very willing to sit there and answer your questions. We simply did not want to do the survey during the Delta wave because you're dealing with people under tremendous distress. And that is not a point at which, you want some social scientist calling up to get the data. And I think that sort of applies to a lot of issues associated with pandemic data. You know, people who have had a death in their household, okay, are not going to want to answer your questions, okay? We shouldn't even be
Unless an
bothering them
Indian
at some level.
journalist comes and asks them on TV.
Maybe, who knows? But I think that we have to take our data collection tasks, whether private or public, with some level of humility, particularly during these times of emergency. Thank you.
No, I want to
Okay,
add
go
to
ahead.
that.
Yeah, okay.
In fact, it is not just journalists, Sujit.
Yeah, I know.
The Sea Voter survey basically assumes that the compliance or the response rate in the survey is going to be the same in the middle of the Delta wave as it was before. So what you are saying, Sonal, it's a very important point, not just about sensitivity, but fundamentally I think it leads to estimates which are biased. And yet, of course, this is Prabhat Jha's work. Sea Voter survey is out there, and I think most of us are looking at it. But it is problematic for one big reason that you just highlighted.
Okay, I think I have 2 or 3 minutes to sum up, and I'll take that privilege and exercise. I don't know which one of you said that let us be humble, because the real fact about the pandemic is that the whole class failed, and they're not willing to admit it. By the whole class, I mean all the major institutions in the world that are supposed to help public policy. Public policy followed what these institutions, these experts, whether it is the WHO, which turned out to be one of the most political organizations. Then you had the CDC asking in December of 2019, they published research based on the last 70 years of pandemics and saying that masks don't matter and saying that social distancing does not matter. I don't know what evidence is there now that these two things matter, but the point is that the evidence is very, very weak. So first, let us be humble, the whole class failed. Now coming to the second part of preparation for the next pandemic. I don't know what one can prepare for the next pandemic. I think as economists, certainly, not as health scientists, we have to worry about the benefit cost of preparing for the next pandemic. And each country has to do that benefit cost. Now, given that a pandemic is a public bad and information flows very, very freely, why should India be investing in preparing for the next pandemic rather than improving its healthcare and taking care of non-pandemic related illnesses and deaths and diseases? So I think we have to be very, very careful. Next, data after data. There is no data that contradicts the following result. Developing countries, on average, have much worse healthcare systems, are poorer, are not so careful. Advanced countries are the most careful, have the best advanced health systems and the best economists and the best modelers. You look at any data and it turns out that in terms of both incidence of disease and deaths, even after accounting for excess deaths, which itself is very, very problematical, and we can ask Sweden as to how problematical it has been. It was the only country that had the courage to go it alone. But I have asked this question at international organizations. They do not have an answer as to why, or they do not care to answer the simple, most robust statistic is that developing countries had much lower incidence of COVID and much lower deaths. So that's the other thing. What we have to recognize, unfortunately, is that COVID, and this is my personal opinion, obviously, had a heavy dose or analysis of COVID, prescriptions for COVID, policies for COVID, had a heavy dose of ideology and politics. If you want to know why it has been one of the deadliest pandemics, that is, in my opinion, humble opinion, the reason. And none of us are willing to identify with either the ideology or the politics. But we are all human beings, we all have ideology, and we all have politics. And it intervened in its various ways to bring about the result that the whole class failed, and this was a massive human tragedy around the world. Last point. Your paper, and I mentioned it in the beginning, what could the governments do and what could they do differently? And in the specific case of this paper, you mentioned you were dealing with India. Now, you did not discuss vaccination for good reason in the sense that it was already very heavy. But in terms of analysis of what India did, it is a major omission of what the government did do and did do very, very well, according to every estimate, in terms of the vaccination. And the politics of why we did not get inputs, etc., is yet another story from the advanced countries who had the inputs. Politics, ideology. Next, poor, migrants, poverty, inequality. Your paper will be helped a lot if you discuss what the government did do in terms of helping the poor, and the poor in India, according to the food distribution system, is the bottom 2/3 of the population. Maybe they'd help them, maybe they didn't, but it was a massive effort, and the paper will really be amiss if it does not discuss what you can come to the judgment of whether they did it well or they did it badly. But to say that you're going to analyze what the government did in India and omit one of the two big success stories of India, in my view, vaccination as well as the alleviation of misery and poverty of the poor. And I think that's all I have to say. Thank you very much.